There's a conversation happening in neurology right now that most patients never hear about because it's uncomfortable. It involves medications. Medications that millions of seniors take every single day, prescribed by doctors they trust, covered by insurance, sitting right there in the medicine cabinet. And the research, published in peer-reviewed journals, not opinion blogs, now links several of these common drugs to measurable memory loss, accelerated cognitive decline, and in some cases, symptoms that look almost identical to early dementia. I'm not here to make you afraid of your medication. I'm here to make sure you're informed, because there is a critical difference between a medication that is right for you and one that may be silently working against your brain. By the end of this video, you will know exactly which 6 drug categories are under the most scientific scrutiny, what the research actually says, and the most important question you should be asking your doctor at your very next appointment. Let's get into it. My name is Dr. James Carter. I've spent years helping seniors understand the gap between what's written on a prescription label and what's actually happening inside the body. And I want to be clear before we go any further. I am not telling you to stop taking any medication. That decision belongs to you and your physician. Full stop. What I am doing is giving you information that the research supports, information that should be part of every conversation between a senior patient and their doctor, but often isn't, simply because appointments are short, time is limited, and these conversations are complicated. You deserve better than that. So let's talk about this properly. Medication number 1, anticholinergic drugs. The first category is one most people have never heard of by name, but have almost certainly taken. Anticholinergic medications. These are drugs that block a neurotransmitter called acetylcholine, which critically is one of the primary chemical messengers involved in memory and learning. The anticholinergic category includes a surprisingly wide range of common drugs. Certain antihistamines, like diphenhydramine, that's the active ingredient in Benadryl and many over-the-counter sleep aids. Certain bladder medications, some antidepressants, even some medications prescribed for dizziness. In 2019, a large study published in JAMA Internal Medicine, following over 280,000 patients, found that cumulative use of anticholinergic drugs was associated with a significantly increased risk of dementia. The effect was strongest in people who had used these medications for 3 or more years. 3 or more years. Think about how many seniors have been taking a nightly sleep aid for far longer than that. Again, this does not mean you must stop, but it does mean this conversation with your doctor is overdue. Now, the second medication category surprised even me when I first looked at the research, because it's one of the most commonly prescribed drug classes in the world, and most people assume it's completely safe for long-term use. Medication number 2, benzodiazepines. The second category, benzodiazepines. You may know these by brand names: Valium, Xanax, Ativan, Klonopin. They're prescribed for anxiety, panic disorders, and insomnia, and they work, in the short term, very effectively. The problem is long-term use, and in seniors, long-term use is extraordinarily common. A major study published in the British Medical Journal found that seniors who used benzodiazepines for 3 months or more had a 51% increased risk of developing Alzheimer's disease compared to those who had never used them. 51%. The proposed mechanism involves the drug's suppression of brain activity over time, particularly in the hippocampus and prefrontal cortex, the 2 regions most critical for memory formation and executive function. What's especially important here is that benzodiazepine cognitive effects can be reversible, especially when caught early and addressed carefully under medical supervision. But that requires knowing the risk exists, and most patients are simply never told. Medication number 3, proton pump inhibitors, or PPIs. Third on our list, and this one affects an enormous number of seniors, proton pump inhibitors, or PPIs. These are acid reflux medications: omeprazole, pantoprazole, lansoprazole, sold under brand names like Prilosec, Nexium, Prevacid. Available over the counter, widely considered benign. Here's what the research shows. PPIs reduce the absorption of vitamin B12, and B12 is not optional for brain health. It is essential for maintaining the myelin sheath that surrounds and protects nerve fibers in the brain. Severe, sustained B12 deficiency causes neurological damage that can be difficult to reverse. A 2016 study published in JAMA Neurology found that regular PPI users had a 44% increased risk of dementia compared to non-users. Now, the research here is association-based, not fully causal, but the biological mechanism through B12 depletion is well understood. And the fix, if PPIs are medically necessary, is often straightforward: regular B12 monitoring and supplementation. Ask your doctor if your B12 has been checked recently. It's a simple blood test, and the answer may matter more than you think. I want to stop here for a moment because I know how this feels to hear. You take these medications because your doctor prescribed them. You trust that system, and that trust is not misplaced. Your doctor is trying to help you, but medicine moves fast. And the research connecting long-term drug use to cognitive decline is relatively recent. Many physicians simply haven't had time to update every patient conversation. That's why you being here, getting informed, matters. You are your own best advocate. Keep going. Medication number 4, statins. The fourth category is one that will be controversial, because statins are among the most prescribed drugs on Earth, and their benefits for cardiovascular health are well documented. But the brain story is more complicated. Statins lower cholesterol, including in the brain. And here's the issue. The brain is the most cholesterol-rich organ in the body. It requires cholesterol to build and maintain synaptic connections, the physical links between neurons. Some patients on statins report what's been termed statin-associated cognitive impairment, brain fog, memory lapses, word-finding difficulty. The FDA added a cognitive impairment warning to statin labels in 2012.
The research remains genuinely mixed. Some studies show protective effects, others show cognitive costs, particularly at higher doses. The individual variation is significant. What this means practically: if you are on a statin and have noticed increased memory or concentration issues since starting, that is a clinically relevant observation worth raising with your cardiologist. There may be alternative approaches, dosage adjustments, or monitoring strategies worth exploring. Medication number 5, sleep aids, Z-drugs. Fifth, a category closely related to benzodiazepines but often considered separately, Z-drugs. Zolpidem, Xyleplon, Ezopiclone. Brand names Ambien, Lunesta, Sonata. These are among the most commonly prescribed sleep medications for seniors, and some of the most problematic for long-term brain health. Z-drugs work by enhancing the effect of GABA, an inhibitory neurotransmitter, to induce sleep. The short-term effect is real. But long-term use has been associated in multiple studies with impaired memory consolidation, increased fall risk due to next-day sedation, and cognitive decline. A particularly important concern: these drugs suppress deep sleep architecture, specifically slow-wave sleep, which, as I mentioned in a previous video, is the phase when the brain clears amyloid beta plaques. So, ironically, the medication helping you sleep may be impairing the very mechanism that sleep is supposed to activate for brain protection. If you are taking a Z-drug nightly, it is absolutely worth discussing sleep hygiene interventions, melatonin strategies, and cognitive behavioral therapy for insomnia, CBTI, with your physician as potential alternatives. Medication number 6, anticholinergic antidepressants. And sixth, a specific subset worth calling out separately: older tricyclic antidepressants with high anticholinergic activity.
Medications like amitriptyline, nortriptyline, and doxepin are still widely prescribed, not just for depression, but for nerve pain, migraines, and sleep. They're inexpensive, they've been around for decades, and many seniors have been on them for years. Their anticholinergic burden, that is, their degree of acetylcholine blockade, is among the highest of any drug class. And as we established with Category 1, sustained anticholinergic exposure has a measurable, documented impact on memory and cognitive function in older adults. Newer antidepressant classes, SSRIs, SNRIs, have significantly lower anticholinergic burden. If you are currently on a tricyclic antidepressant, this is a specific, actionable conversation to have with your prescribing physician. So let me give you something concrete to walk away with. The one question to ask your doctor: can you review my current medications for anticholinergic burden and potential cognitive effects? That single sentence will tell you immediately whether your physician is up to date on this research, and it will open a conversation that could genuinely protect your brain. What to bring to that appointment? Write down every medication you take, prescription and over-the-counter. Include sleep aids, antihistamines, antacids. Include dosages and how long you've been taking each one. Then ask, are any of these on the Beers criteria list? The Beers criteria is a list published by the American Geriatric Society, specifically identifying medications considered potentially inappropriate for older adults, including many with documented cognitive risks. Your doctor should know it immediately. What to ask about alternatives? For sleep, CBTI therapy, melatonin, magnesium glycinate, sleep hygiene protocols. For acid reflux, H2 blockers like famotidine have lower dementia association than PPIs. For anxiety, evidence-based non-pharmacological interventions, buspirone, or lower anticholinergic alternatives. I want to be direct with you. This is not about refusing medication. Some of these drugs are genuinely necessary. The goal is informed partnership with your doctor, not medical rebellion. But you cannot advocate for yourself in a conversation you don't know needs to happen. Now, you know. Let me quickly recap the 6 categories we covered today. 1. Anticholinergic drugs, including common antihistamines and bladder medications. 2. Benzodiazepines, anxiety and sleep medications like Xanax and Ativan. 3. Proton pump inhibitors, acid reflux drugs that deplete B12. 4. Statins, important cardiovascular drugs with a complicated cognitive profile. 5. Z-drugs, sleep aids like Ambien that may suppress brain-protective deep sleep. 6. Older tricyclic antidepressants with high anticholinergic burden. If you take any of these, bring this list to your next appointment. Ask the questions I gave you. And remember, the goal is always the most effective, safest path for your individual health. If this video helped you, please share it with someone you love who takes regular medications. It could genuinely matter. And if you want to know the 5 foods and 3 daily habits with the strongest research support for protecting memory, that's coming in my next video. Take care of your brain, and I'll see you soon.